Hello, Linda Peterson here. We're on Chapter 11, the lungs and respiratory system. Here's your objectives. The chest. The respiratory system supplies oxygen to cells and removes carbon dioxide using processes of ventilation and diffusion. Carbon dioxide diffuses from pulmonary capillaries to alveoli and is exhaled. There are three main structures within the thorax or the chest: the mediastinum and right and left pleural cavities. The mediastinum is positioned in the middle of the chest. Within it are the heart, the arch of the aorta, superior vena cava, lower esophagus, and lower part of the trachea. The right lung has 3 lobes and the left has 2. The anterior chest contains mostly upper and middle lobe with very little lower lobe. The posterior chest, mostly remarkable point about the posterior chest is that it is almost all lower lobe. The diaphragm and intercostal muscles are primary muscles of inspiration. During inspiration, the diaphragm contracts and pushes abdominal contents down, while intercostal muscles push the chest wall outward. Combined efforts decrease interthoracic pressure, creating negative pressure within the lungs. During expiration, muscles relax, expelling air as intrathoracic pressure rises. There are 4 main functions of the respiratory system: supplying oxygen to the body for energy production, removing carbon dioxide as a waste product of energy reactions, maintaining homeostasis, which is your acid-base balance of arterial blood. By supplying oxygen to blood and eliminating excess carbon dioxide, respiration maintains pH or acid-base balance of blood. Maintaining heat exchange, less important in humans, but it's still important. Control of respirations, normally our breathing pattern changes without our awareness in response to cellular demands or other feedback. Normal stimulus to breathe for most of us is an increase in carbon dioxide in blood or hypercapnia. The infant's body systems all develop in utero, but the respiratory system alone does not function until birth. Birth demands its instant performance. Respiratory development continues throughout childhood. Assessing respiratory status of infants, children, or adolescents follows sequence as for adults. There are differences worth noting. Infants must be undressed to diaper for examination. Keep the infant covered when not examining to prevent exposure and cooling. Conduct the examination while the infant is calm. Examining a crying infant is difficult. By ages 2 or 3, the child is usually cooperative. Prior to that age, you need to develop a relationship with the child to improve cooperation. Conditions associated with poor respiratory function are often through environmental tobacco smoke exposure, which include sudden infant death syndrome, negative behavioral and cognitive functioning, and increased rates of adolescent smoking. Sample assessment questions include: has the child had any frequent or very severe colds? Is there any history of allergy in the family? For a child under 2, at what age were new foods introduced? Was the child breastfed or bottle-fed? Does the child have a cough or seem congested? Does the child have noisy breathing or wheezing? Are any smokers in the home or in the car with the child? The enlarging uterus elevates the diaphragm 4 centimeters during pregnancy, and this decreases the vertical diameter of the thoracic cage. But this decrease is compensated for by an increase in horizontal diameter. Increase in estrogen level relaxes the chest cage ligaments. Although the diaphragm is elevated, it is not fixed. It moves with breathing even during pregnancy, which results in an increase in tidal volume. Growing fetuses increase oxygen demand on the mother's body. In the aging adult, costal cartilages become calcified, which produces a less mobile thorax. Aging lungs are more rigid in structure and harder to inflate. These changes result in an increase in small airway closure, and with aging, histological changes also occur, so less surface area is available for gas exchange. Lung bases become less ventilated as a result of closing off of a number of airways. Histologic changes also increase the older person's risk of postoperative pulmonary complications. Assessing respiratory status of older adults usually follows the same procedures as other adults, although there may be structural and functional differences noted. The posterior thoracic stooping or bending or kyphosis may alter thorax wall configuration and make thoracic expansion more difficult. Questions to ask: have you noticed any shortness of breath or fatigue with your daily activities? Tell me about your usual amount of physical activity. For those with a history of chronic obstructive pulmonary disease, lung cancer, tuberculosis, how are you getting along each day? Any weight change in the last 3 months? How much? How is your energy level? Do you tire more easily? How does your illness affect you at home and at work? Do you have any chest pain with breathing? Do you have any chest pain after a bout of coughing or after a fall? Subjective data. Do you have a cough? When did it start? Was it gradual or sudden? How long have you had it? How often do you cough? And is there any special the time of the day or just on a rising? Does the cough wake you up at night? Do you cough up anything such as phlegm or sputum? How much? What color is it? Do you ever cough up any blood? Does it look like streaks or frank blood? Does the sputum have a foul odor? How would you describe your cough? Hacking, dry, barking, hoarse, congested, bubbling. The cough seems to come with anything: activity, position, lying down, fever, congestion, talking, anxiety. What activity makes it better or worse? What treatments have you tried? Have you done prescription or over-the-counter meds, a vaporizer, rest, position change? Does the cough bring on anything such as chest pain or ear pain? Is it tiring? Are you concerned about it? Have you ever had shortness of breath or difficulty breathing? Is it affected by position, such as lying down? Does it occur at any specific time of day or night? Do shortness of breath episodes associated with night sweats, or cough, chest pain, or bluish color around the lips or nails? Any wheezing? Do episodes seem to be related to food, pollen, dust, animals, season, or emotion? How does the shortness of breath affect your work or home activities? Any chest pain with breathing? If so, please point to the exact location. When did it start? Is it constant or does it come and go? Describe the pain: burning, stabbing. Is it brought on by respiratory infection, coughing, or trauma? Is it associated with a fever, deep breathing, unequal chest inflation? What treatments have you tried? Have they been effective? Do you smoke cigarettes or cigars? You always want to ask how many packs per day and for how many years. Have they ever tried to quit? Were they ever successful quitting? Do they want information on smoking cessation? Do they have any environmental exposures? Where do they work? What kind of work do they do? Are they at a factory, a chemical plant, a coal mine? Do they farm? Are they outdoors in a heavy traffic area? Do they wear anything to protect their lungs? Any PPE, any mask, anything like that? Is there any monitoring of exposure if they work in those environments? Do they have periodic examinations, pulmonary function tests, or x-rays? Self-care behaviors. When was the last time you had the following? A TB skin test, a chest x-ray, pneumonia or influenza immunization? Those are all good questions. Thoracic assessment. This is a great video on YouTube on assessing the respiratory system. Summary checklist on an examination. Inspection first. Check the thoracic cage, respiration, skin color, and condition, the person's facial expression and level of consciousness. Palpation, confirm symmetric expansion and tactile fremitus, detect of any lumps, masses, or tenderness. Percussion, lung fields, and estimate diaphragmatic excursion. We don't typically do this anymore. Auscultation, assess breath sounds and note any abnormal or adventitious breath sounds. Barrel chest also refers to an increase in the anterior-posterior diameter of the chest wall, resembling the shape of a barrel, most often associated with emphysema. Most often you'll notice the sign in patients diagnosed with COPD, also known as chronic obstructive pulmonary disease. COPD is a complex condition that is a result of chronic airway inflammation and progressive structural changes from prolonged exposure to irritants. The most common irritant is tobacco smoke. People with this condition have damage to the airways and the air sacs inside their lungs, and this damage makes it harder for people with COPD to breathe, making them feel very short of breath. Pectus excavatum. Pectus excavatum is an abnormal development of the rib cage in which the sternum grows inward, resulting in a noticeable and sometimes severe indentation of the chest wall, also known as sunken chest. It can be corrected with minimally invasive surgical technique called the NUR procedure, with traditional open surgery. Pectus excavatum occurs in both children and adults, but is most commonly noticed in the early teen years. Due to the pectus, patients may have less space in the chest, which can limit heart and lung function. The symptoms can be both physical and psychological. Physical symptoms can include shortness of breath with exercise, decreased stamina compared to peers, fatigue, chest pain, irregular heartbeat. The NUR procedure is after a tiny camera is inserted into the chest to guide the procedure. 2 small incisions are made in either side of the chest, and a curved steel bar is inserted under the sternum, individually curved for each patient. The steel bar is used to correct the depression and is secured to the chest wall on each side. The bar is left in place for 3 years and later removed as an outpatient procedure. Abnormal respiration patterns. Eupnea is normal breathing. Sighing is an involuntary inspiration that is 1.5 to 2 times greater than normal tidal volume. Sighing breathing is observed in subjects suffering from anxiety with no observed organic pathology. Dyspnea is a subjective sensation of difficulty breathing. Paroxysmal nocturnal dyspnea is described as attacks of severe shortness of breath that wake the patient from sleep. They have to sit up to catch their breath, and most commonly this is a symptom of heart failure. Orthopnea is also seen in heart failure. Patients are unable to breathe comfortably lying flat. They must be sitting or propped up to breathe without difficulty. Kind-Stokes is a pattern of crescendo, decrescendo respirations followed by a period of apnea. It is well described in patients with heart failure, usually observed while asleep and is a result of disordered central control of breathing. Bradypnea is a respiratory rate that is lower than normal for their age. Tachypnea is a respiratory rate that is greater than the normal for age. And hyperpnea is increased volume with or without an increased rate of breathing. Blood gases are normal. Respirations that result from anoxic brain injury. This will often progress to apnea depending on the underlying cause. Apnea is the absence of breathing. This signals a life-threatening situation in which the patient will quickly succumb unless rescue breathing is instituted immediately. Hyperventilation is overventilation above that needed for the body's CO2 elimination. This results in a decrease in PaCO2 and respiratory alkalosis. Hyperventilation can be driven by chemoreceptor stimulation due to metabolic acidosis. Hypoventilation is underventilation below that is needed for the body's CO2 elimination. It is inadequate to maintain a normal PaCO2. Adventitious lung sounds are abnormal sounds that are heard when auscultating a patient's lungs and airways. These sounds include abnormal sounds such as fine and coarse crackles. Crackles are sometimes called rails. Wheezes, sometimes called bronchi, pleural rubs, and stridor. Adventitious lung sounds are important clues used for diagnosing numerous cardiac and pulmonary conditions. Crackles are discontinuous, brief popping sounds similar to the sound of a hook and loop fastener being pulled apart. Wheezes are continuous musical sounds, high or low pitched, usually more pronounced on expiration. Pleural rubs are creaking or grating sounds that have been described as being similar to walking on fresh snow. Stridor is a loud, high-pitched sound heard during inspiration but may also occur throughout the respiratory cycle. Atelectasis is a complete or partial collapse of the entire lung or area of the lobe of the lung. It occurs when the tiny air sacs, alveoli, within the lung become deflated or possibly filled with alveolar fluid. It is one of the most common breathing complications after surgery. Lung Sounds Link, easyauscultation.com is a wide-known site used for listening to lung sounds. It does a very good job. I recommend you listen to it. Common respiratory conditions. Atelectasis was covered in the previous slide. The rest are going to be covered after this slide. Pneumonia. It's an inflammation of terminal bronchioles and alveoli, and it may be caused by bacteria, fungi, viruses, mycoplasma, or aspiration of gastric secretions. In viral pneumonia, it tends to produce a non-productive cough or clear sputum. Bacterial pneumonia, however, causes a productive cough that may produce white, yellow, or greenish sputum. Other clinical findings associated with pneumonia include fever, tachypnea, dyspnea. Crackles and wheezes may be heard on auscultation of the lungs. Bronchitis is inflammation of mucous membranes of bronchial trees caused by viruses or bacteria. Patients may complain of substernal chest pain aggravated by coughing. Bronchi and crackles frequently heard on auscultation with wheezing heard after coughing. Chronic bronchitis characterized by hypersecretion of mucus by goblet cells of the trachea and bronchi result in a productive cough for 3 months in each of 2 successive years. It's caused by irritants such as cigarette smoke and air pollution or by infection. Symptoms are productive cough, increased mucus production, and dyspnea. Findings on auscultation are bronchi sometimes cleared by coughing. When sufficient mucus occludes alveoli, crackles may be heard. Acute bronchitis, alveoli are hyperinflated and cough is present, lasting up to 3 weeks. Most cases are viral. Large airways are narrowed from capillary dilatation, increased mucus production, loss of cilia function, and swelling of the epithelium. More cases occur with smokers, aging adults, children, and in the winter months. On inspection, you'll notice a cough, productive or non-productive. Palpation, no pain, no increased fremitus. Percussion, you'll have resonance. Auscultation, they may be clear. Emphysema. It's a destruction of alveolar walls that cause permanent abnormal enlargement of air spaces. Smoking causes 80 to 90% of this. On inspection, you'll see an increased AP diameter, a barrel chest, use of accessory muscles to aid respirations. Sometimes they're tripoding. Hello, Bailey. On palpation, decreased fremitus. On percussion, hyperresonance. Yes, I can't play right now. Go sit down. Auscultation, decreased breath sounds, prolonged expiration, muffled heart sounds, occasional wheezing. Classic appearance of a patient with advanced emphysema is underweight with barrel chest and short of breath with minimal exertion. Other findings reveal diminished breath and voice sounds, possible wheezing or crackles on auscultation, and decreased diaphragmatic excursion on percussion. Asthma is a hyperactive airway disease characterized by bronchoconstriction, airway obstruction, inflammation. It occurs in response to allergen or pollutants, infections, cold air, vigorous exercise, or emotional stress. Clinical findings include increased respiratory rate with prolonged expiration, audible wheezes, dyspnea, tachycardia, anxious appearance, possible use of accessory muscles, and cough. Prolonged expiration, expiratory, and occasional inspiratory wheezes are sometimes seen, and diminished breath sounds are common findings with auscultation. Pleural effusion is collection of fluid in the interpleural space. Gravity settles fluid in dependent areas of the thorax. Fluid subdues all lung sounds. On inspection, you'll have increased respiration, dyspnea, dry cough, tachycardia, and asymmetric expansion. Percussion will be dull. Auscultation, decreased or absent breath sounds may have crackles or pleural rub. The patient may complain of sharp pain with inspiration. It is typically very painful. So the nurse is caring for a patient who is suffering from chronic obstructive pulmonary disease. He coughs frequently and produces a thick white sputum. During auscultation, the stethoscope should be placed where? Over the scapula to enhance adventitious lung sounds, so that it is barely touching the skin to avoid auditory artifacts. Over the left lung fields first, or in one position long enough to hear an entire inhalation-exhalation set. Hopefully you picked D. Always avoid bones during auscultation. The diaphragm should be firmly pressed against the skin. When auscultating the lungs, the nurse should compare side to side. Pneumothorax is air in the pleural space. There are three types of pneumothorax: spontaneous, usually COPD with emphysema, cystic fibrosis patients, TB, lung cancer, and HIV, PCP pneumonia, most likely due to the formation of small sacs of air in lung tissue that ruptures, causing air to leak into the pleural space. Traumatic occurs following penetration of the chest by either injury or surgical procedure, and tension develops when air leaks into the pleura and cannot escape. On inspection, you'll see tachypnea, apprehension, bulging at interspaces. On auscultation, decrease or absent sounds, no adventitious sounds. Signs vary depending on amount of lung collapse. With minor collapse, the patient may be slightly short of breath and anxious and have chest pain. Stop it. With large amount of lung collapse, patient may be in severe respiratory distress, including dyspnea, tachypnea, and cyanosis. Decreased chest wall movement on the affected side may also have paradoxic chest wall movement. If severe, there may be tracheal displacement toward the unaffected side with a mediastinal shift. Hemothorax is blood in the pleural space. It results from blood in the pleural space caused by injury to the chest, but also may be a complication of thoracic surgery. Signs are similar to those described for pneumothorax, although it is common to note distant muffled breath sounds and dullness with percussion over the affected area. Tuberculosis. Tuberculosis is a contagious bacterial infection caused by Mycobacterium tuberculosis, primarily in the lungs, but the kidney, bone, lymph nodes, and meninges can also be involved. The patient is usually asymptomatic in the early stages of the disease. Initial clinical manifestations consist of fatigue, anorexia, weight loss, and fever. Characteristic findings later in the disease is cough that becomes increasingly frequent, producing a mucopurulent sputum. On inspection, the cough can be non-productive, becoming productive. Yellowish-green sputum, but may be blood-tinged, dyspnea, orthopnea, fatigue, and weakness. The skin is moist. They usually have night sweats. On percussion, resonant, dull, over effusion, but again, we don't typically percuss. Pulmonary embolism. When a blood clot gets caught in one of the arteries that go from the heart to the lungs, it's called a pulmonary embolism, also a PE. If the clot is big or the artery is clogged by many smaller clots, a PE can be fatal. PEs usually travel to the lungs from a deep vein in the legs. You'll notice tachycardia, crackles, and wheezes. Can be small and lead to dyspnea, or they can have a saddle PE that leads to sudden death. Their PaO2 usually is less than 80%. Their ABG is respiratory alkalosis. They're diaphoretic, and they're hypotensive. Lung cancer is uncontrolled growth of anaplastic cells in the lungs. Agents such as tobacco smoke, asbestos, ionizing radiation, and other noxious inhalants can be causative agents. Most common initial symptom reported is a persistent cough. Weight loss, congestion, wheezing, hemoptysis, labored breathing, or dyspnea are other manifestations that occur with advanced disease. Lung sounds may be normal or diminished over the affected area. If there's a partial obstruction of airways from a tumor, wheezes may be heard. On this page, small cell lung cancer is your most deadly. So item B is your most deadly because it advances so quickly. Chest tubes. Whenever fluid or air accumulates in the pleural space, the pressure becomes positive instead of negative, and the lungs collapse. Chest tubes are inserted to drain the pleural space and reestablish negative pressure, allowing for proper lung expansion. There may also be inserted in the mediastinal space to drain air and fluid postoperatively, but typically we do it on the side, about the 5th intercostal space. They're approximately 20 inches long and vary in size from 12 to 40 French. The size inserted is determined by the patient's condition. Larger tubes like 36 to 40 French are used to drain blood. Medium 24 to 36 French are used to drain fluid, and small 12 to 24 French tubes are used to drain air. There are two types of suction control, water and dry. The water suction control chamber uses a column of water with the top end vented to the atmosphere to control the amount of suction from the wall regulator. The chamber is typically filled with 20 centimeters of water. When the negative pressure generated by the suction source exceeds the set 20 centimeters, air from the atmosphere enters the chamber through the vent on top, and the air bubbles up through the water, causing a suction breaker effect. As a result, excess pressure is relieved. The amount of suction applied is regulated by the amount of water in this chamber and not by the amount of suction applied to the system. An increase in suction does not result in an increase in negative pressure to the system because any excess suction merely draws in air through the vent on the top of the third chamber and just creates noise. The suction pressure is usually ordered to be 20 centimeters of H2O, although higher pressures are sometimes necessary to evacuate the pleural space to lower the pressure. Can be used for frail patients. Lower pressure can be used for frail patients at risk for tissue damage with higher pressure. To initiate suction, the vacuum source is turned up until gentle bubbling is present in the chamber. Excessive bubbling does not increase the amount of applied suction, but does increase the rate of evaporation of the column of water and the amount of noise made by the device. Chest tube nursing management. Monitor the patient's clinical status, assess their vital signs, lung sounds with the suction off, and pain. Assess for manifestations of reaccumulation of air and fluid in the chest. You'll have decreased or absent breath sounds, significant bleeding, which is greater than 100 mL an hour in the drainage system, chest drainage site infection. You'll see drainage, erythema, fever, increased WBCs, or poor wound healing. Notify the physician for a management plan. Evaluate for subcutaneous emphysema at the chest tube site. Encourage the patient to breathe deeply periodically to facilitate lung expansion and encourage range of motion exercise to the shoulder on the affected side. Encourage use of sinus spirometry every hour while awake to prevent atelectasis or pneumonia. Never elevate the drainage system to the level of the patient's chest because this will cause fluid to drain back into the lungs. Secure the unit to the drainage stand. Change the unit if the collection chamber is full. Do not try to empty it. Mark the time of measurement and the fluid level on the drainage unit according to the unit standards. Report any change in the quantity or characteristics of drainage, such as clear yellow to bloody, to the physician and record the change. Always notify the physician if drainage is greater than 100 mL in an hour. Check the position of your drainage container. If you knock it over, stand it back up. Clamping of the chest tubes no longer used. If the chest tube becomes disconnected, immediately reestablish the water seal system and attach a new drainage system as soon as possible. In some hospitals, when disconnection occurs, the chest tube is immersed in sterile water, about 2 centimeters, until the system can be reestablished. It is important to know the unit protocol on how to react to this. Appearance of a new air leak warrants assessment of the drainage system to identify if the air leak is coming from the patient or the system. It's typically the patient. Although controversial, some clinicians clamp the chest tube for a few hours prior to removal. Just depends where you're at. So before caring for the patient, the nurse reviews the test results. A chest radiographic report shows that there is atelectasis in the right base. During lung auscultation, what would the nurse expect to find? A. Increased phragmitis in the right base. B. Diminished breath sounds. C. Wheezing throughout. Or D. Symmetrical chest expansion. Hopefully you picked B. Phragmitis is palpated, not auscultated. Wheezing throughout may or may not be present if the patient has asthma-related atelectasis. This will vary case by case. Chest expansion is noted through inspection and palpation, not auscultation. It may be asymmetrical if the atelectasis is pronounced. This is the end of your lecture. Thank you and have a good day.